Well, happy Heart Month, everybody. What a great way to start out the month. My name is Alicia, and this is Tiffany, and we are cardiac clinical case managers, also known as cardiac educators to our patients. Um, our group is excited to bring back these popular doctor talks, starting with Dr. Dauterman, who we all might know and love. Um, as you were welcomed, you were provided with a survey. If you could take a minute to fill that out and let us know what you thought about this presentation and what you might like to see in the future, that would be greatly appreciated. We thank you for your time.
As some of you may know, Dr. Dauterman is one of our own cardiologists here at Southern Oregon Cardiology. He earned his medical degree from John Hopkins, where he was among top 3. Prior to medical school, Dr. Dauterman served as a Peace Corps public health volunteer in Africa, where he met his beautiful wife. They're married on our own Harris Beach on the Oregon coast and settled in beautiful Southern Oregon. Cardiology and interventional cardiology specifically has come a long way since he started and continues to progress. Dr. Dauterman helped establish both the TAVR and the carotid stent programs at Rogue Regional Medical Center. Please help us welcome Dr. Dauterman for his talk titled The Tale of Two Hearts.
Thank you. Thank you. Okay. Everyone hear me okay? Does that work? No? Okay, Kim. How's that? Is that a little better? Maybe? Kim, a little more volume there? Just a little bit there? Okay, great. Okay, let me get all hooked up to all this. How's that? A little better? Too loud? Okay, great. Well, welcome to the talk. It's nice to see a good crowd. Certainly do my best to make it worthwhile, make it worth your time. We had a beautiful sunny morning today. We have an audio-visual extravaganza for you. Going to cover a lot of information. You know, they say a picture is worth 1,000 words, so we're going to cover a lot of information, a lot of slides, but hopefully it's worth your time. So February is Heart Month, or it's Valentine's Day, or Valentine's Day is in February, and it seems a natural time to have Heart Month. This American Heart Association designates it Heart Month. So we're going to spend time focusing on heart care this month. And the nice thing about cardiology or cardiac care is it's really one of the huge success stories in modern medicine. Wonderful ways to diagnose people. We understand diseases really well. Not perfectly, but really well. Great diagnostic modalities, great treatments, really a real success story. And that's important because, you know, heart disease is the leading cause of death. 38% of us will die of heart disease. So that's a good place to put all your efforts into research and the like over the past 60 years or so. Now, there's a lot of, you know, we live in this age of information, and there's just so much information out there and trying to figure out what's real and what isn't. So I'm going to try and help with that today. We also live in an age of, we have tons of choices. You know, we all have more wealth than we've ever had in, you know, the world. And so we have all these great choices we can make. So I think what I'm going to try to do today is make it so you're as informed and educated about heart disease as possible so you can make good choices for yourselves. Because it is hard to filter through all the noise that's out there. If you go on the internet, you'll find all kinds of information. And what you really want to do is how to know where to find good sources. Places like American Heart Association, American College of Cardiology, Johns Hopkins, Mayo Clinic, Cleveland Clinic, Harvard. You want to try and stay away from quack.com. And there's all sorts of stuff out there, and not all of it is good. There's a lot of misinformation. There's a lot of fake news. There's all sorts of stuff out there. So you got to be careful what you get into. And so today's talk, I entitled it The Tale of Two Hearts. And as you kind of get all this information, you can imagine, you know, there's was kind of aimed at, kind of like the Richard Scarry characters, if you remember them, Pig will and pig won't, or, there's people who are educated and informed and can make the right decisions for themselves, and how far that can take them in terms of preventing heart disease and treating heart disease if they get it, and doing it with the best possible research and treatments out there. And then there's other folks who go way off on a weird tangent and not to their benefit. So I'll do my best to inform you and make it worth your while. So a few things here. So first of all, no conflicts of interest. I'm not being paid anything for this, or not in anyone's pocket. So you can also think of me a little bit as like the Lorax. I'm here, the Lorax from Dr. Seuss, he spoke for the trees. I speak for your heart. I speak for your cardiovascular system. I'm here to try and give you the truth the best we know it. Today we're going to cover a lot of topics. We're going to talk about anatomy and pathology, which I think you'll see some really cool stuff maybe you haven't seen before. We're going to talk about saving hearts without opening chests, preventing stroke without blood thinners if you have atrial fibrillation, which is very common, smartphones and all the technology that's hooked up with them. Do supplements really help? There's a lot of them. And obesity, weight loss, and living to be 100. So we're going to cover a lot. I've been given 2 hours. I'll probably be an hour and a half or something, so bear with me. So anatomy. So, the heart sits right in the middle of the chest. I mean, it's not over here. It doesn't look like a Hallmark gift card. It's right there in the center of the chest underneath the breastbone, because the breastbone is very protective, and it sits in this little sac called the pericardium. It's a little protective sac which has about a tablespoon of lubricating fluid in it called the pericardium. It's not really lubricating fluid, but it's kind of like that. So when the heart squeezes, it is nice and smooth surface. Sometimes people get inflammation in their pericardium and they get something called pericarditis, or they get a very stiff pericardium. Very rare, not very often. And here's another picture of the heart sitting in the chest. The right ventricle is on the front, the left ventricle is behind. There's your aorta, actually your pulmonary artery, your aorta, actually pulmonary artery here, your aorta here, and here are your lungs out here, and your diaphragm's down here. So kind of like the man behind the curtain. You're seeing the heart behind the curtain. Looks a little different than you expect maybe. And here's the heart here, a little fat on the outside, and the coronary arteries run in these grooves. And the heart has a lot of similarities to car engines. I use car engine analogies a lot. And the reason that is, well, first of all, this is a Model T. There's a little Model T engine. Some people have that, that's okay. Some people have the Lamborghini. But there's a lot of similarities. You have the motor, you got the fuel lines, you've got the electrical system, you got the valves, all that stuff. And the interesting thing about the heart is it pumps about 90,000 times a day on average. By the time you hit age 65, it's about 2 billion heartbeats. So it's been going ever since you've been in your mother's womb, no vacations, no breaks. So the cardiac pump function, this is a picture of an echocardiogram. This is a normal looking heart. This is a nice V8 engine here. You can see the left ventricle is squeezing nicely, left ventricle, right ventricle, mitral valve, tricuspid valve, the atria. And so that's what we look like, or look at when you get an echocardiogram. And this is a weak heart over here. And you can see right over here, compared to this is squeezing nicely. This one is weak. This is someone who has congestive heart failure and a weak heart, maybe a left ventricular ejection fraction of like 25% or so. So those are things we're looking at. And then this is cardiac echo. And this is a nice normal heart right here, left ventricle, right ventricle. And we have this also with CT here. And then this is a picture of a weak heart. You can see that one's just not squeezing well, and also a weak heart over here. So there's a lot of pretty amazing cardiac imaging, and once again, the heart's like a pump. Now the valves of the heart, a little different than the valves of a car engine. There's no pistons and all that, but we have 4 heart valves. So there's 4 pumping chambers, 4 heart valves. So Here are what the valves look like. If you cut away on the heart, there's the tricuspid valve and the pulmonic valve and the mitral valve and the aortic valve. So the purpose of the valves is to open and close at just the right time to keep the blood moving forward. If we took away all your heart valves, every time the heart would squeeze, half of the blood would go forward, half of it would go backwards. So the purpose of the valves is to keep the blood moving forward efficiently. And when you're young, these valves are soft and supple. By the way, here's a little cutaway of the heart. This is the tricuspid valve with all these little ropes, and here's the pulmonic valve. Then if you cut away on the left ventricle side, here's the mitral valve with all these little ropes holding onto these two bed sheets here. So those are the pictures of the valves. And here's the valves when they're all closed. Here's the pulmonic and aortic valves, 3 parts, the leaflets. 1% of people have a 2-part valve, like Arnold Schwarzenegger and Mick Jagger. They had their valves replaced. And then here's your mitral valve and your tricuspid valve here. And that's what they look like when they're closed, but usually 2 are closed and 2 are open. So this, when the aortic and pulmonic valves are open, when the heart's squeezing, these valves pop open, and these valves go shut. These look like big bed sheets, and they prevent the blood from going backwards up into the lungs here or back out into the body, like the liver here. And then when the heart relaxes and the blood flows from the lungs down into the heart, the mitral and tricuspid valves open up, and the aortic and mitral valves close to prevent the blood from coming backwards into the heart and drowning the heart. Now the problem is, as you can imagine, with the heart pumping 2 billion times by the time you hit age 65, these valves can wear out. They can get either blocked up or leaky. Just plain old wear and tear, a little bit like plumbing. Now, the fuel lines to the heart, the coronary arteries, they're right here. They go down the front of the heart and the side of the heart and the bottom side of the heart. These are the fuel lines to the heart muscle. So when someone's saying someone's having a coronary, someone's having a heart attack, a myocardial infarction, this is where the action is. So this is a wax cast. If you inject wax, latex down the coronary arteries and then dissolve all the muscle and leave the latex behind, this is kind of what the coronary system looks like. So your aortic valve is right up here, and then all these little fuel lines go right down to the heart muscle, and the only job they have is to carry blood to the heart muscle, similar to the fuel lines of a car engine. So when the heart pumps that red oxygen-rich blood out to the body, about 10% of it comes right back to the heart muscle. So this is another picture, an even better picture. This is actually from National Geographic, where they injected latex down into all the arteries, and it worked its way down, and really great, goes down into all the capillaries, and then they dissolved away all the heart muscle and valves. And look at that. That's all capillaries and arteries. And that's what we plug up as we get older, right? Cholesterol, atherosclerosis, cholesterol plaque. We'll come back to that. And look at the imaging we get here now with CT scans. Look at the high resolution. These are 3-millimeter arteries, 1/8 of an inch in diameter arteries that are moving. You know, when you take these pictures, you can't tell someone, okay, hold still, heart, hold, don't move. You know, we got this scanner that can take a picture from here to here on one heartbeat and get all this resolution. And this is your cardiovascular system. As the lower axis is what I'm speaking for, this whole thing in your body. Now, there are also nerves that go to your heart, cardiac nerves. They go from your heart up to your brain. So you might be getting the pressure, the tightness, the heaviness, the elephant on your chest. Some people, their nerves, for whatever reason, they don't work as well, especially when you get diabetes. Some people can have heart attacks, don't even know it. So, I mean, there's a whole variety of ways the nerves talk to you. And these nerves that go to your heart are the same ones that go to your esophagus and your stomach. So some people think they're having indigestion and other people are having a heart attack. I mean, some people think they're having indigestion and they're having a heart attack, and other people think they're having a heart attack and they're just having indigestion. You can't always tell. Here's your electrical system just to your heart. Here's the own sinoatrial node. This is your natural pacemaker. And there's these little electrical wires. They're not copper, they're all muscle wires. They go down to your AV node. This is your toll gate, which then goes down to your ventricles. And these little, so the circuit goes from here, electrical circuit goes from here down to here, and it goes through here, out to here, and that's what stimulates the heart muscle to squeeze. So there's electricity that's flowing through your heart with every heartbeat, true electricity, and that's what our EKGs are based on. An EKG is nothing more than a simple voltmeter, and this measures the voltage generated by your heart. And people have all sorts of electrical circuitry issues as they get older. Very common. So here's what the circuits look like again, your natural pacemaker, AV node, and then the circuits that go down to your heart muscle. And this is cutting it all away and what it looks like. So our electrophysiologists, who really do nothing more, there are electricians, right? I'm one of the plumbers. I do valves and coronary arteries. We have electricians that really focus on these circuits. And they do all sorts of things to modify these circuits. And sometimes these circuits wear out and people need a pacemaker. Sometimes people have unstable circuits and they need a defibrillator. Sometimes people have an extra circuit in here and you have to cauterize it. There's all sorts of things that people get as they get older. So this electrical circuit gives you the EKG, and we learn all kinds of information from the EKG. So this is, for instance, a normal electrocardiogram. This would be a normal person. This is someone who's having a big heart attack. This is an anterior ST elevation myocardial infarction. This is the big one. And we call these tombstone ST elevations because it looks like you put a little tombstone in there. And this person has a complete blockage in the artery on the front side of their heart, and about 40% of their heart muscle is in the process of dying. So our job is to open up that blocked artery. But the first thing is we get this EKG, or the paramedic gets the EKG and activates the system and gets you in to open up the blocked artery. This is someone you can see here. This is a very slow heartbeat, nothing, 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 heartbeat. So this is someone who has heart block. One of their electrical circuits is interrupted and the top of the heart is not talking to the bottom of the heart. So this person gets a pacemaker. This person has atrial fibrillation. It's very irregular, and you can see it's just a very chaotic, basically in atrial fibrillation, there's a portion of the heart where the electrical circuits short out. And that portion of the heart, instead of having a nice organized rhythm, is going about 300 to 600 times a minute. And the rest of the heart, thankfully, the toll gate at the AV node slows it down. So this is your normal. When you check your pulse, this is your pulse, but all this other stuff is chaotic. So this is atrial fibrillation. And then this is death. This is ventricular fibrillation. This is if your whole heart, all of your electrical circuits just short out. You have chaotic, disorganized electrical activity. The heart cannot squeeze. Blood pressure goes to zero, and that's when you die. So that's ventricular fibrillation. That's cardiac arrest. So atherosclerosis. We're going to talk a little bit about atherosclerosis, plugging up of one's arteries. This is what it looks like. In the old days, they used to do an autopsy on someone. They'd feel the arteries, and they'd say, boy, there's hardening of the arteries here. Calcium, a lot of calcium. They'd cut open the artery, and they'd find all this clot and cheese type stuff, and they'd say, oh, it must be too much cholesterol. Well, what it is injury to the heart or injury to the lining of the blood vessels, and you get atherosclerosis, and that can plug up your arteries. So these are the carotid arteries. You can plug up the arteries up to your brain. This is your aorta. You can plug up your aorta. Tough to do, but people do it. And this is actually with an aneurysm here. So you can see the blood vessel comes down here, and then you get a weakening of the blood vessel wall. It starts to stretch out. These can rupture. This one plugged up. This is what an aneurysm looks like. These should be really smooth. You should be able to take them, and when you're young, you could take your arteries and just pinch on them and roll them around in your fingers, and they're very soft. This is hard living. And this is what it looks like under a microscope. This is where the blood's flowing, and then you have all this plaque over in here. This is the cholesterol plaque and the inflammation and the smooth muscle cells and the calcium. It's all the injury to the arteries. So your arteries are not simply pipes, right? They're living, breathing blood vessel. I mean, they're living, breathing cells. So there's things we do to injure those arteries. So if you have blockages, do not do this at home. Do not do this at home. This is Drano, liquid plumber that will not fix your blocked arteries. So, this is an open artery right here. And then as you get older, you can get this plaque in there, atherosclerosis, hardening of your arteries, and it starts to restrict blood flow. You can think of it as kind of like water flowing through a garden hose. So initially you get some plaque in the walls of the garden hose, and then sometimes the plaque will rupture, expand, and then it'll start to limit flow through the garden hose. And you can get a severe blockage right there. There's a severe blockage. And And then you can plug up the artery sometimes. So one key concept, one key paradigm change from about 25 years ago when I was finishing up, when I was in residency and fellowship, was, it used to be thought that, atherosclerosis, these blockages, it's like, well, you got a 30% blockage this year, and next year it's a 32% blockage, and the following year, if you go down and have a lot of cheeseburgers, it's 36% the next year, and then if you eat really well, maybe it's 37% the next year. It's just a slow accretion, slow growth of plaque. And we know that's actually not the case with these plaques in your arteries. Think of these plaques in your arteries as like little pimples. You got this you got this cholesterol gruel and inflammation and these plaques throughout our arteries, carotid arteries, coronary arteries. If all of us have yellow streaks at least, maybe some of you have been perfect, but most Americans, you've got plaque in your arteries. And these plaques, they can be more like, think about them more like Mount St. Helens. The top of the plaque comes off. Most people who have heart attacks, if you come in with a completely blocked artery, if they went back and looked at those people, we know that most of those people, if you went back a day or a week in time, they had a 10, 20, 30% blockage. Then the top of the plaque comes off. The blood is flowing through this little 1/8 inch diameter artery. It sees the cholesterol gruel and the inflammation. The blood is not terribly smart. It has white blood cells and red blood cells and sugar in it and clotting factors. And the clotting factors get activated. The clotting factors are always looking for a roughed up surface. So if you scratch your arm on a blackberry bush, right, you'll bleed and then you'll clot, right, or you bleed to death. Or if a surgeon operates on your knee, you clot or you bleed to death. So the blood's flowing around always looking for a roughed up surface. If the blood sees a roughed up surface in your coronary arteries, a little 1/8 inch diameter artery, and it sees a roughed up surface, it wants to clot. It just says, there's a roughed up surface, I have to clot. Otherwise, this person is going to bleed to death. Well, you've just had too many donuts or something, right? And so you can plug up an artery. And so anyway, that's how we call it plaque rupture, acute coronary syndromes. And people are rupturing plaques all the time. You just hope you don't plug off the whole artery. I don't know if all the time, but there are people who rupture plaques, they don't always occlude off. So this is kind of what it looks like a little bit. You've got, when you start off, when you're young, you've got you got 3 layers to your arteries. So it's like 3 layers of rug. And you roll it up and you've got this lumen down the middle, kind of like where the water's flowing in the garden hose. And we kind of injure this, depending on, the big 9 are smoking, diabetes, high blood pressure, high cholesterol. Those are the big 4 that you can control. And then what you eat and do you exercise. And then as you get older, and if you're a guy, those are risk factors, can't help you there. And then there's genetics. So there's kind of 9 things that contribute to injuring your arteries. We're always injuring or healing our arteries. There's always this injury, healing going on. Hopefully you're having more healing than injury. So anyway, you can, as you get older, I'm 55, you start getting this type of stuff. And hopefully the cap on this, hopefully this is kind of quiet and the cap is stable like a dried out pimple. Hopefully it's not a whole bunch of active inflammation in the thin cap because you're abusing your arteries. And then what can happen is you get this cap and all these smooth muscle cells and calcium and inflammatory cells. And then sometimes what happens is the top of the plaque comes off. This ruptures out, and the blood sees all that. And then you get a clot, right? That's plaque rupture. That's how most heart attacks happen. So rupture of fibrous cap, all this stuff right in here. So this is what it looks like under the microscope. So this is a stable plaque. This is where all the blood's flowing. The only thing protecting this artery, this blood flowing from all this junk, is that little cap in there, right? We all have them, or we're getting them. Most of us. Maybe some of you don't. My wife's a healthy eater. She might not. But so here's a ruptured plaque. So you got this little plaque, and then you see this blood clot formed on here. And then this is an occluded artery. So the top of the plaque came off, and then you plug up your artery. This is kind of what it looks like. So when we go in to fix people with having heart attacks, they've kind of ruptured their plaques. So this is kind of what a heart attack looks like. This is a little video.
The culprit responsible for your heart attack is called plaque.
That's an artery.
Plaques are fatty deposits that line the arteries that feed blood to your heart. Over time, the plaques enlarge and narrow the artery. A heart attack occurs when the plaque ruptures or explodes, causing a blood clot to form and totally close off the blood supply to an area of your heart. That darkened area can form a scar.
So there's a heart attack. Heart attacks come in all sizes. Depends on how much heart muscle is damaged. They come in all sizes, small, medium, large, catastrophic. So that's a big heart attack. This is what a stent is. Now, stents, they're very small, little pieces of metal. The purpose of them is to prop open the artery to ensure good blood flow down to the heart muscle. Where stents are helpful, and they're also not helpful in other situations. They're not helpful in every situation for sure. But here's what a heart attack. This is where stents really earn their stripes. Other stuff, not so much. So this is when we're in the cath lab, someone's coming in with a heart attack, they're having an inferior ST elevation myocardial infarction. We have an angiogram, we're injecting contrast dye down the artery. Steve Frederickson, put your hand up, Steve. He was the guy who founded our first cath lab here, and or started the cath lab, and he's done many of these type of patients. Anyway, we inject contrast dye down the artery. It's like seeing water in a garden hose. It comes down here, and this is the catheter. We're injecting the contrast dye, and right here the artery stops. So this whole part of the heart muscle that depends on that artery is in the process of dying. We take a balloon. It's not like a party balloon. It's more like, let's see here. Not finding my little pointer. Here it is. There it is. So there's a balloon that's shaped like a hot dog. We inflate the balloon, and it pushes the plaque and all that cholesterol grummus and clot to the side. And then afterwards, that's what it looks like. You see all those arteries that go way out there. Those are little shotgun pellets. The person got hit a long time ago. So anyway, but there's a stent down there now. So there's a balloon and then a stent. And the purpose of a stent is to prop open the artery to ensure good blood flow down to the heart muscle. So this is where stents are helpful. But there has been a paradigm shift with stents. Stents are not for everybody, okay? So it used to be thought when I came out of fellowship back in like 2003 or so, it was like if you had a 70% blockage in a patient, but the patient was doing well, they've just been saying, every time I go for a walk, I walk, half an hour and I get a little tiny bit of chest tightness and it goes away with a little nitroglycerin, and I've had it for 3 years. It used to be at that time, if you did an angiogram for the patient, you'd say, you know what, we need to fix that blockage. Because if we didn't, you left the patient at risk of having a heart attack. Well, that paradigm has changed. So when are stents helpful and when are they not? Because you've probably seen, in the press, like, stents are not helpful. Well, this is where you have to use your critical thinking skills. That stents are incredibly helpful and life-saving in people in the process of having an active heart attack or at risk or threatening to have a bigger heart attack. They've come in with unstable symptoms, or they haven't had a little tiny heart attack and they're at risk of a big one. That's where stents are incredibly helpful. If someone just has stable symptoms or no symptoms and they have about a 60-70% blockage, we know based on these two trials that have come out, the ischemia and the courage study, that if you treat someone with aggressive medical therapy, statins, aspirin, good medicines, and if someone says, I can live with these symptoms, they're not that bothersome, my heart's pumping well, and they have a severe blockage, you can just treat someone medically. And they do as well as with stents because they have a stable plaque. Because remember, we talked about heart attacks usually occur 10, 20, 30, 40, 50% blockages. So if you have a 70% blockage, it may stay that way the rest of your life. Okay, so we know that people do as well in stable situations with medical therapy versus stents. It's the unstable situations where stents are life-saving. Now we're going to go on to another thing, another topic. So heavier than air flying machines are impossible. This is what was said in 1895 by Lord Kelvin, head of the Royal Society. So he was wrong. This is from Western Union in 1876. This telephone thing has too many shortcomings to be seriously considered as a means of communication. The device is inherently of no value to us. So there's all this new stuff coming out, and there's all these great quotes. This is from Thomas Watson, who was the president of IBM in 1943. I think there is a world market for maybe 5 computers. There's probably 150 in this room. So anyway, so we're going to talk a little bit about the structural heart program. This is all new stuff. This is the fixing hearts without opening chests type thing. And so there's a whole variety of things. So there's the TAVR program, the minimally invasive aortic valve. There's the MitraClip. There's the mitral valve and valve. There's the closing atrial septums. There's the Watchman device. And then there's the lariat procedure where you lasso the atrial appendage. So this is heart valves. We're going to do heart valves. We'll do TAVR first. Some of you have had a TAVR valve here, I know. So these are the valves. You've seen that. And this is the aortic valve. This isn't a nice young person. This is probably like a nice 16-year-old kid. 3-part valve, nice and soft and supple. And this is what happens. 4% of people will get a severely blocked up aortic valve to the point where it either kills them or they get a new valve. It's a lethal condition. It's the most common heart valve condition, and if it becomes severe and is causing you symptoms or your heart starts to fail, then it becomes a lethal condition. And there's about a 50% chance of dying in 2 years once it's severe, because this is basically like strangling your heart. When the heart's squeezing the blood out, when you're young, that valve just pops open and the blood rushes out easily. These valves, when they get severely blocked up, it's like when the heart goes to squeeze that valve, instead of going like this, it goes like this. And the heart's having to work really hard to shove the blood through an ever-shrinking hole. And eventually the heart will fail or you die suddenly. And so once it gets to be severe and you start to have symptoms or your heart starts to fail, you need a new valve. And there's no valve softener, there's no valve conditioner that's going to make that valve soft and supple again. I bet you can find something online at quack.com, but do not use it. And there are all these valves right here. These are some of the valves. There's mechanical valves. These are the tilting disc, mechanical, ball and cage valves. These are the bioprosthetic cow or pig valves. You can see they're 90% man-made. There's only about 10% that's actually tissue. They don't look like they came out of the slaughterhouse. When someone says they have a cow or pig valve, it's more man-made than anything. It's all sterile and very high-tech. And this is kind of what the valves look like when they open and close. They're really one-way check valves, right? When the heart squeezes, the valve opens, the blood rushes out, and when the heart relaxes, the valve starts to come backwards, it closes the valve. So the blood can flow in one way, but if the blood starts to go in the other way, it pushes the valve shut. There are no ropes, there are no pulleys, there are no levers, there are no gears or motors. It's just a flap. So this is if you have aortic stenosis, the most common valve condition. This is survival versus age. So if you have, a blocked up heart valve, people are doing fine, but once they start to get symptoms about here, then they start dying quickly, right? So it's a lethal condition. Once you get symptoms and once your heart starts to weaken, then it becomes a lethal condition. There are a lot of people with mildly or moderately blocked up valves we watch. When it's severe, we watch them until they get symptoms or until it gets to be critically blocked up or if their heart starts to weaken. So there's about a 50% chance of dying in over a 2-year period once you reach a severely blocked up aortic valve that's causing symptoms. So this is the standard approach. This is open heart surgery, life-saving procedure, really started in the mid-1960s, right? And this is what it looks like. This is your heart, real live heart here. This is a rib spreader. You cut down the breastbone and then you spread the ribs apart and put someone on the heart-lung machine and then do whatever you have to do on the heart. Cut out the old valve, suture in a new valve. And then this is the minimally invasive TAVR procedure, which has really been a success story within cardiology itself. And this is what a stent valve looks like. These are $33,000 valves. This is what the hospital pays to Edwards and Medtronic and all them for these. Kind of crazy, really. But you can see here's fingers holding one. So this is a stent valve, and this is what it looks like when you're putting it in. And this is a cadaver. This is when they were doing the figuring this out. And this is like, for instance, a blocked up aortic valve. And that just, that's the blood's getting pumped through that small hole right there. And there's all this plaque there and all. And then this is when you put in the valve and what it looks like. So it's like you basically put a valve in the valve. And this is kind of what it looks like, the procedure. So this is all done on a beating heart. About 20% of people go home the next day, 60% of people go home in 2 days. Here's a blocked up aortic valve. It's not opening very well, putting a big load on the heart. Sometimes we'll have people with a blood pressure in their arm of 120 and the blood pressure in their heart's like 240. So you can see how it fails. We go up the aorta. Remember, your arteries are like a big superhighway system. Once I access an artery, we can travel about anywhere in your body. We take a wire up and across that valve. So we have it parked in the left ventricle. We take a balloon about the size of a big pen cartridge. We take it across the valve. We burst pace, and we inflate the balloon. This, again, looks like a hot dog, not a party balloon. We stretch out that valve, and then we crimp the stent valve onto that balloon, and we go up your aorta. So this is one of the tubes. This is one of the delivery system tubes. And here's the valve. The valve is crimped onto the balloon. And you take that up and around the arch, and you take it across that valve. And then you burst pace, so there's no pulsatile, there's no pumping of the heart when we're implanting. And you inflate the balloon, it opens up the valve, you deflate the balloon, you take out the balloon, and you've got a valve within your old valve. The old valve actually helps hold it in place. Then you take out the equipment, and you're done. Which is really pretty ingenious. Alain Carpentier from France actually invented that. So anyway, and what's interesting is this was started back in 2012. It was initially approved for high risk and prohibitive risk, so inoperable and high risk patients, people who had expected mortality rates of around 8% if they went for surgery. That's considered high risk, 8 to 15%. And then it was shown to be as good as open heart surgery, and then it was approved for intermediate risk patients, medium risk patients, and was shown to be as good or better than those patients. And then in low risk patients, you know, someone who doesn't have a lot of other medical issues, death at 30 days, open heart surgery 1.1%, TAVR 0.4%. So in the healthy group, TAVR did as well or slightly better. Death or disabling stroke at 1 year, open heart 2.9%, TAVR 1%. If you remember, this is the group if you do nothing, 50% die at 2 years, and the other 50 are not doing too good, right? So, life-saving procedure. It's not for everyone. We always have to do a CT scan and review everything at valve conference with the cardiothoracic surgeon and the cardiologist and the radiologist, and put our heads together and figure out each person. It's kind of like fitting shoes, you know, not one size does not fit all. Some people are better served with surgery, some with minimally invasive valves. This is something called a sentinel device. If a person has the right anatomy, we put this device in from the right wrist. We deploy it in the innominate artery here. So this artery goes out to the right arm. This is your aorta. And then we place this device in your left common carotid artery. So when we're deploying the valve, as you can imagine, sometimes particles break off and you can go up and have a stroke. About a 2% chance of stroke with open heart surgery or a minimally invasive valve. That could be mild or major stroke. But this device, when you use it, it'll catch particles. You know, so we use that when we can. We can't use it in everybody, but we try to when we can. And how did we do in 2019? We started here at Rogue Regional Medical Center. I think there's about 350, 400 places in the country doing. There's about 1,400 open heart surgery programs in the United States. About 400 of them do TAVR, I think, roughly. And so good places you're competing against. We did 99 patients, had these structural cases last year. We did 90 TAVR patients, 5 mitral valve and valve, 4 mitral clips, and we had 0 deaths at 30 days. That was we did a good job last year for folks. And it's a good team. We have cardiothoracic surgeon, interventional cardiologist, anesthesiologist. We have an imaging cardiologist. Oh, Mick got in there. Hold on. He got a TAVR. And he actually went back on tour, I think, 4 or 6 weeks after he had his TAVR. Okay. So we're going to move on to mitral valves. So this is an echocardiogram, what we look at. This is the right ventricle, the left ventricle. This is the mitral valve. This is a valve one upstream from the aortic valve. This is the mitral valve between the main pumping chamber of your heart and your lungs. So when the heart squeezes, you want this valve to close so the blood doesn't go in the reverse direction. When this heart is squeezing, you can see right here that this part of the valve looks okay, but this part of the valve is kind of like flopping back here. You can see they just don't meet together. You see how like one's up here, one's a little lower? That's called a flail leaflet. And that leads to us looking at, oops, sorry. And when we look at it, we use color Doppler, and there's not supposed to be any color. This measures flow. And every time the heart squeezes, this area should be just black, and this area has a whole bunch of color. This is mitral regurgitation. This is severe torrential mitral regurgitation where you have flow going in the reverse direction, and you can get heart failure, your lungs can fill up with blood, and it's kind of like drowning. You get pulmonary edema. So you got a severely leaky valve there. Now, for people who are at increased risk for surgery, it's not for everybody, it's a small percentage of our patients. Most people go right now for mitral valve repair or replacement through either the sternotomy or a minimally invasive repair from the side. Surgeons here do a fantastic job. But for the right person, we can do a mitral clip, and this is like a little clothespin, and we can put that right where the leakiness is, and this is kind of what it looks like.
The blue flow filling the left atrium illustrates severe mitral regurgitation, or MR. The percutaneous mitral repair system consists of catheters and the MitraClip device. The catheter is introduced over a guide wire that has been placed using standard techniques.
So we go up the vena cava up to the heart.
The dilator is used to gradually advance the guide into the left atrium.
And you puncture from one side of the heart to the other.
The guide wire and dilator are removed. The clip is gradually introduced into the left atrium. The clip is precisely positioned above the leak in the valve.
So a lot of degrees of freedom. You can move different
The
ways.
clip arms are opened in the left atrium for final positioning.
It's like engineering on steroids. Really impressive.
Color ultrasound imaging identifies the severe MR illustrated here with blue flow. The clip is advanced into the left ventricle below the valve leaflets. The clip is retracted and closed to hold the leaflets together to reduce MR. If the MR reduction can be further improved, the leaflets are released and the clip re-advanced. Positioning adjustments may be made and the leaflets are grasped again to reduce MR. The double orifice opening allows blood to flow on both sides of the clip. The grasp and MR reduction are assessed before the clip is deployed. The catheters are then removed.
So that gives you a little feel. So we started doing that last year, and for the right person, it's the right procedure. It's not for everybody, but it's you can see where things are going. This is mitral stenosis. So if someone has, there are some people who get a bad valve, and they get a tissue valve, a cow or pig valve, within their mitral valve, either because of a leaky valve or a blocked up valve. So this is mitral stenosis if the valve gets severely blocked up. It just does not open very well. And so if you had open heart surgery, you know, initially this is kind of what your valve looks like. But over 10 or 15 or 20 years, your artificial valve kind of does that. It gets tough and thick and leathery and calcified and can either get blocked up or leaky over time. So this is one thing we can do is we can put one of these TAVR valves in the surgical valve. So we can dilate a balloon across the atrial septum. We take the device down here into the left ventricle. We inflate a balloon with the valve within it, and you get a valve in a valve. So this is a 3D transesophageal echo of the valve. This is a surgical valve that's about 15 years old, and you can see it does not open very well. You see that little orifice right there? All the blood is flowing through there. That is a tight valve. We then take equipment, we cross from one side of the heart to the other. And after we put in the valve, this is what it looks like. Oops. That is what it looks like right there. You can see the difference there to there is pretty dramatic. So the top left is before, and the bottom right is after putting in the valve. This is without opening the chest. These are high-risk patients who, a lot of them inoperable, would not have been able to have redo open heart surgery, just too sick. And this is kind of what it looks like when we're putting in the device. This is inflating a balloon across the atrial septum, so we have a big enough channel to go from the right heart to the left heart. So it's a big device. And then this is what it looks like. We burst pace, and there's the stent valve within the surgical valve. We're inflating a balloon during a burst pace, about 200 beats a minute, so the pressure levels off. And you deploy it, and then you deflate the balloon, stop burst pacing, take it back out, and you've got a valve in a valve. So that's a nice thing. We started doing this in spring of last year, and these are two of our patients. One got a mitral clip, one got a mitral valve and valve, and they both did well. So now we're going to go to heart rhythm issues, strokes, atrial fibrillation. 30% of all strokes are due to atrial fibrillation. That's what it looks like on the EKG. The feared thing with atrial fibrillation is stroke. This part of the brain is damaged from a stroke. There's a clot that formed within the heart and traveled up to the brain and plugged up the artery, and there was no blood flow out to the brain. And sometimes a stroke can convert into a hemorrhagic stroke where you can bleed into that area. And you can see this blood, this bleeding is shoving the blood to the side, and this person died. And this is the feared complication of stroke. You know, many people fear stroke more than death because it can be very debilitating. So 30% of all strokes are due to atrial fibrillation. 10% of people have atrial fibrillation over the age of 60. So, you know, a lot of you out there have it or are going to get it. And me too, you know. I'm in the category, I'm with you. And where most clots form in the heart, basically what happens is when the heart's in a normal rhythm, the heart's going like this. All chambers of your heart. When you go into atrial fibrillation, remember you get this disorganized, chaotic electrical rhythm. That portion of the heart, instead of going like this, is just going like this. Not the entire heart, but there's a portion of the heart, the atria, that's just going like that. When the heart does that, the blood stagnates. And if the blood stagnates, it can clot. And if the blood clots and travels out of your heart and goes up to your brain, you get a stroke. It can go to your leg, it can go to your gut, it can cause all kinds of things. I had one person went to her arm. The surgeon had to fish it out of her artery. She was really upset about it. I said, it was really lucky it did not go to your brain. It was unfortunate, but if you wanted it to go anywhere, that's where you want it to go. The surgeon just fished it out, the clot, and she went home in 2 days. So she really dodged a bullet. This is where they form in the heart, this little windsock called the left atrial appendage. We don't know exactly what it does there, but it's there, and that's where clots form. And if you do a wax cast, latex cast of it, this is what it looks like. You can imagine if you have stasis, you can see how clots can form in there really easily, right? And this is what it looks like underneath the echocardiogram. We do a transesophageal echo. We can see this atrial appendage. This is a nice, clean left atrial appendage. And this is what it looks like when you get a clot in there. Sometimes we'll do a transesophageal echo when someone has atrial fibrillation. We'll see a little clot. This is the left atrial appendage, and this is a clot sitting right in there. If that clot moves out of there and goes across the mitral valve, across the aortic valve, and up to your brain, that person has a stroke, right? The way to prevent that is, well, is aspirin the right answer? There's your brain. There's aspirin. So if you have atrial fibrillation, always talk with your cardiologist or doctor. If you have a risk score, there's always a risk score we use. Some people have a low risk score, and aspirin is the right answer. But if your risk score is high, aspirin will reduce your risk of stroke by around 15%. Instead, you know, the tried and true thing that's been around a long time is warfarin, but now there's new stuff. There's Pradaxa, there's Xarelto, There's Eliquis. They have this stuff all on TV, I'm sure, because there's a lot of people with atrial fibrillation. And the wonderful thing about the new meds is they're easier to take. You don't have to go get your blood checked all the time. The downside of the new medicines is they're expensive. And then there's something called a Watchman device, where you put a little plug in that windsock I told you about. And this is kind of the new technology. And this is the Watchman device. We do it here. You go up the inferior vena cava, you puncture across from the right atrium to the left atrium, and you put a little plug in that windsock. And this is kind of what it looks like. So here's the windsock. Take a little picture of it under the fluoro. Put a delivery catheter up into the windsock. And this is a self-expanding device made of nitinol. And you unscrew it, and you're left with this plug in the left atrial appendage. And then your body will cover it over the next couple of months and seals off. You do have to be able to take a blood thinner like Coumadin or Xarelto or Eliquis or something for about 3 months after this. And how do people do? Well, actually, if you get a Watchman device compared to Coumadin, this is the risk when people have events. So usually stroke or death or some type of clot traveling somewhere in your body over time. And the dark line is Watchman and the jagged line is Coumadin. It does as better or at least equivalent to Coumadin. So it's a treatment option for patients now. Okay, we're going to shift gears. So covering a lot of ground here. That's all kind of the sexy, fun tech stuff. It's all kind of fun to see. A lot of you won't apply to. Some of you it will. So how about smartphones? What's out there? What's out there? So this is what an EKG machine used to look like. Very portable, very small. Could put it in your 18-wheeler. And this is what an EKG machine looks like now, for the most part in the hospital. But now there's all these little EKG machines that look like that, little smartphones. So everything's getting smaller. There's actually an interesting company called LifeCore Cardia. I don't own any stock or anything. I think it's privately held. But it's one channel, and you can put this on your smartphone, and you use 2 fingers, and it gives you an EKG. You can download it PDF, you can download it to your cardiologist, you can have it officially analyzed. And there's actually now a 6-channel one. You rest on the back side of this, it's a piece of metal, you rest it on your knee, and these other 2 you put it in each hand, and it gives you a 6-lead EKG. Pretty fancy, actually, pretty cool. And this actually has FDA approval. So FDA grants first ever clearance for 6-lead personal EKG device. And then there's also the Apple Watch. Now, is this going away? No. Mayo Clinic's starting to put big money into this. Apple's putting big money into all this smartphone stuff. So you're going to see a lot more of this type of stuff coming out. Here's the Apple Watch with the EKG detection, identifying. This was actually in the New England Journal of Medicine, which is probably the premier medical journal. And, they had like 440,000 patients. Could the Apple Watch identify atrial fibrillation? That type of stuff. So this is all coming. Here's a continuous glucose monitor. You put this on for 2 weeks. A little tiny needle. You don't even feel it. Or maybe hardly. And you monitor your blood sugar continuously, which is pretty cool. And there's all these insulin infusion pumps now too. So you got that thing monitoring your insulin. You got this little pump giving insulin. It's, pretty soon they'll be talking with each other. It'll be like having your own pancreas, but outside of your body. I mean, it's really impressive. Here's a pedometer. They're very cool. This one even gives you confetti. My wife's a big fan of that. I like it when I get confetti. You get it if you get to 10,000 steps. And all they are is they have an inertia motion unit in them. That's this little chip. They use them on the robotics teams all the time, and they use them in combines and planes and all these things. If you see a plane that you push the button, it'll just right itself. It's using an inertia motion unit. These combines out in the Midwest, they plot the grid, they go around each corner, and then they put the button, and then the combine will go around efficiently and even better than a person driving it. So they use an accelerometer, gyrometer, and a magnetometer, i.e. a compass. And, it counts how many steps and how far you go. And this is all on your smartphone. Pretty cool. There's EEG called the Muse. This is basically a electroencephalogram. This gives you brain waves. I'm not recommending it, but it looked kind of cool. Funny, I went onto the website just to check it out, and they're all sold out. They use it for meditation. You know, it's funny how you sell things. But for people with seizures or other things, it might be interesting. There's gluten testers, these portable gluten testers, if you're really tuned into your gluten. There's mobile breathalyzers. Get one for every college student. I don't know. You can, if you're at 0.08 or above, you better not drive. Or whatever it is now. Air pollution, air quality. You can do that. So there's all these little attachments you can have for smartphones. Okay, shifting gears again. Herbal supplements and prescription medicines. I see this a lot. I came here, this was interesting. This was one of my patients when I got here. They came in and they said, "Doc, I'm on 4 meds. Or you're prescribing 4 meds. You gotta cut some of this out." I was like, "Oh, okay. Well, let's look through them. Do you have a list of all your meds?" I always ask all my patients to bring in their medicines, everything they're taking, whenever they come in. And she brought in all her pills and then this written out. And I was like, oh, okay, let's see what you got. Well, there's that and that and that. And then these are the ones I've prescribed right here. Those are mine. Now these are everything else. And I said, well, I don't know if my pills are the issue. I mean, there's cat's claw and there's Arth's report and wild yam and ginkgo and grapeseed extract, and she wasn't feeling well. And I wasn't sure really why, but anyway, there's 71 supplements, and some of these have multiple supplements. There's some combination, there's hawthorn and all this stuff, and she had palpitations and her heart was jumping around and racing, and I said, why don't you just stop all that stuff? I want to tell you what, make a deal. For a week, just keep mine and knock out all this stuff. She goes, well, shark cartilage, it's all natural. I said, well, sharks are natural. Doesn't mean everything natural is good for you, right? I mean, sharks are natural. They're not good for you. Some wild mushrooms like death cap, those, can kill you. So she stopped and her heart rhythm just settled right down. So for the cure of his ailments, I always like this kind of quote. For the cure of his ailments, real and imagined, the man in the street has always been drawn to the promised magic of exotic substances. Nothing is more closely bound up with human hopes and fears than the recapture or preservation of health. And the way I think about it is, people are desperate for good health. Everyone wants to live forever. And if someone is out there, if I feel sometimes I could buy some grape Kool-Aid. I've told some of my patients this. I could buy some grape Kool-Aid, put on their Kent's artery cleaner. I could have my brother write a little testimonial saying, you know what? I was about dead, my arteries were plugged up, I drank this stuff, it cleaned everything out, I can put it on the shelf, and people will buy it. People will buy it, okay? But today, this is why you gotta have some critical thinking today. So many patients view herbals and supplements as natural and therefore safe, and some of them might be just fine. And there's a lot of crooks out there, though. I'm just here to tell you. For instance, ephedra, this is a small minority. This is what can happen. If you remember Steve Belcher, Baltimore Orioles pitcher from Southern Oregon, he was trying to lose some weight. He took ephedra and died, during spring training. So why do we have the Food and Drug Administration, the FDA? There's all this criticism. It's like, oh, the FDA is terrible. Well, it's probably one of the best organizations out there, especially if they're reasonably funded. It started back in the time of Teddy Roosevelt. It's always good to know the history of why something was established before you tear it down, right? So it was started for 2 reasons. One is, in the tenements, there are all these immigrants. These people would come by, there'd be some kid who'd have tuberculosis, they'd have some other thing, and they'd open up their suitcase and say, hey, you buy some of this stuff, whatever it is, it'll cure your kid. Immigrant hand over their money, poor person hand over their money, give it, kid still dies, they're out their money. And so there's all this stuff, right? All this unproven stuff you can just put out there whatever you want. And then there was also this Upton Sinclair, The Jungle. It's a really interesting little book. I've read excerpts, I haven't read the whole thing. But, you know, at the slaughterhouses, you know, it was not the meticulous, clean place that we've come to expect nowadays, that we take for granted. He says they use everything about the hog except the squeal. And, you know, this is no fairy story and no joke. The meat will be shoveled into carts, and the man who did the shoveling will not trouble to lift out a rat even when he saw one. You know, so I mean, you know, it's an interesting story, but based on food and drugs, the FDA came about in Teddy Roosevelt's time. And there was all kinds of these patent medicines, right? And for drugs, the Food and Drug Administration says, well, anything you buy that's under the FDA purview, you know, aspirin, prescription meds, there's a lot of over-the-counter stuff that the FDA said, you know, this is pretty safe stuff, you don't have to have a prescription for it. But you have to prove purity, so what you say is in it is in it. It has to have a certain safety profile. Nothing's perfect. Every drug has certain side effects. Aspirin could cause stomach ulcers. It can also reduce your risk of heart attack if you have coronary disease. And efficacy, it has to provide some value. So the FDA requires 3 things for drugs. For nutritional supplements and herbal remedies, here's what we know. It's not required to register the product, not required to get FDA approval, because it's in the food category. It's like Wonder Bread. You just have to know that. It goes in the Wonder Bread category under the FDA. They have really, the only time they get involved is if the coffins start piling up. If there's no coffins piling up, they just, okay, that's, so you just have to know that when you're buying this stuff. Not required to perform pre-approval testing for safety or efficacy. Not required to prove that the product contains the ingredients listed. So this is from Rob Califf. This is when he was at Duke. He's one of the big cardiovascular researchers, and then he actually became the head of the FDA after this. But what the FDA can do is if there's evidence of unsafe outcomes in people who take herbal supplements, it can then act to require that the advertising or labeling of the supplement include that information. But it cannot require that a company collect that information if there is no indication of a problem. Right? So if the coffins aren't piling up, you know, I can put whatever I want out there as long as it's not harming anyone, right? Most consumers absolutely do not understand that these supplements have not been tested. They presume that because they are on the shelves and they are labeled, that the FDA has given some assurances that they're safe. There's a lot of ignorance among the public about what it is they're consuming. In current legislation, the law says supplements are presumed safe unless proven unsafe. Kind of the opposite of the law for drugs. They're really presumed unsafe until proven safe. So I'm not saying you shouldn't take them, but you have to go into it with your eyes wide open. Frankly, I'd save my money. Buy a multivitamin, you know, get some exercise, eat right. Don't do 71 supplements. So my challenge to you, right? Number 1, be skeptical. This is where education comes into play, knowledge, very powerful. So I'm a bit suspicious. In my experience, there's no such thing as a free lunch. That's true. So think like a scientist. Scientists still have value. Is there a legitimate research to back up a claim? You know, is it a randomized study? Is it prospective? Is it double blind? Is there placebo involved? So you know the best studies are basically you have studies going on at multiple centers. The person prescribing the drug doesn't know if it's placebo or medicine. The patient doesn't know if it's placebo or medicine. You follow people along over time, and you have clear outcomes you're following. Death, heart attack, stroke. Those are easy to measure in the world of cardiac disease, right? And so a lot of the stuff that's approved by the FDA for heart disease, for instance, you know, American College of Cardiology, American Heart Association, I mean, the number of millions of dollars, billions of dollars that have gone into all that, you know, that has value, I think. There are some natural prescription meds. Here's foxglove in your backyard. In the old days, they used to kind of chew it until they got some nausea. This is William Withering. It's about a 300-year-old drug. It's in digoxin, lanoxin, digoxin. Old drug. Don't use it too much anymore. Certain situations we do, mainly for AFib or heart failure. There's also the yew tree. And that is Taxol, and they use it in folks with breast cancer. And they used to put it on stents to prevent blockages from coming back within the stent. There's also leeches, where we made, and you know, you can go out and get your leeches if you want. But I mean, you can also, they put it in Hiridin. That's a medicine to prevent the blood from clotting, because leeches, they hook on and, they don't clot up, right? They got little stuff in their secretions to keep things from clotting. Rattlesnakes, we used to use that to keep things from clotting when we were doing, fixing people who didn't want their blood to clot, and medicine called integralin. We don't use that much anymore. Actually, if you get heparin, that mainly comes from horse mesenteries. So anyway, so we're going to shift gears again. So I'm giving you a whole lot real fast. So obesity. Well, it's a problem. Supersizing of our society. It's hard, right? I mean, we live in an age of like amazing food, and you don't have to wash dishes, you don't have to walk to work, there's no field to plow, you walk from here out to the car, you drive home. I mean, life's pretty nice. But, this is the side, this is the problem with all that, right? And this is sad, right? Because that's all parents for the most part. Has our land of plenty become a toxic environment? Probably, This is a great movie if you ever want to watch a fun movie, Super Size Me. You can go up and get voodoo donuts. I remember seeing this, they brought one of these in the cath lab the other day, kind of as a display exhibit or something. This is the maple cream bacon bar. It's got cream inside, fried cream inside, and then bacon on top. And they didn't put the cherry on top of it. And then this is the Heart Attack Grill. Anyone seen the Heart Attack Grill in Las Vegas? No? Okay, well, if you go to the Heart Attack Grill, I mean, you can really kind of get all kinds of stuff. Here we have flatliner fries, deep fried in pure lard. We have the single bypass burger, the double bypass burger, the triple bypass burger, the quadruple bypass burger. We have whipped cream in shakes, butterfat shakes. There's all sorts of some really questionable, more than questionable, probably downright, probably wrong things. But anyway, I'll show you a little video clip on the...
New calls to close down a restaurant that prides itself on unhealthy meals. A customer at the Heart Attack Grill, that's the name of it, was rushed to the hospital after eating a sandwich called the Triple Bypass Burger. Health advocates say the restaurant should be shut down. ABC's Ryan Owens has that story.
I'll have a double bypass.
Good choice.
The Heart Attack Grill is a bit like Hooters with a hospital theme. Waitresses dressed as nurses, customers in surgical gowns.
Get your arms in over here.
Free food for anyone over 350 pounds. The menu features a single, double, triple, or quadruple bypass burger, complete with unlimited flatliner fries cooked in lard. So when a man eating a triple bypass at the Las Vegas restaurant Saturday night suddenly appeared to need one, a lot of people thought it was a publicity stunt. An onlooker shot this cell phone video of paramedics taking the man with chest pains to the hospital. The restaurant's owner, in his doctor's costume, says it was the real deal.
Okay. It's coming to Medford next month. Just joking. Might be, actually. Who knows? So the solution. So by the way, we're probably got about 15 minutes or so to go. So bear with me. And if you have to go out and stretch your legs, go for it. So the solution, well, so, the solution is, it's pretty simple. I'm just going to go through a few things on weight loss and avoiding this. So the increased solution. So, there's kind of a three thing. One's increased physical activity. The other is decreased food intake. And there's better food choice. And there's all kinds of diets out there, right? The South Beach diet, paleo diet, keto diet. I don't know. There's all this Jenny Craig and Weight Watchers. And, at the end of the day, whatever you end up doing, I mean, it's really just chemistry, right? You either burn it up or you put less in. You always try to make good food choices so you're not injuring your arteries. But, if you take it in, you either got to burn it up or it goes out the other end or it gets stored, right? I mean, so there's people, I have patients who are 350 pounds say, I don't eat anything. I'm like, well, probably not. That's not true. It's just not, I mean, I have so many patients where, you know, they've lost 20 pounds. I have so many patients who lost 20 pounds, 40 pounds, 100 pounds, and I ask them, like, well, what'd you do? You know, what'd you do different? And they just said, I stopped eating. Or, you know what, I just went for a walk every day, rain or shine. Or, I mean, they made some adjustment, right? And it's always interesting to hear, but it's pretty simple, really. Decreased weight, improved levels of homeostasis hormones, and you get lower blood pressure, lower blood sugar, lower triglycerides, increased HDL cholesterol. So, for instance, if you watch that Super Size Me movie, there's a guy who just eats supersized McDonald's meal every meal for a month. It's really interesting to see what happens to him. And I've also seen people lose 20 pounds, 40 pounds, 100 pounds, 10 pounds, and all of these things get better. Blood pressure gets better. People on 4 or 5 blood pressure medicines, they lose some significant weight, they're down to 1 or 2. See it all the time. Sugar gets better. Triglycerides get better. HDL gets better. You look and feel better. Joints are happier. Cures sleep apnea in many. Because sleep apnea is kind of an epidemic of us all just being a little overweight or a lot overweight. Not sure what I did there. Hold on. So weight loss, this is a few words, but I'll just go through this. So it's complicated, maybe. I mean, for some folks it really is, and it's not simple. Some people, a lot of people really struggle. We all struggle. I think one thing that helps me kind of think about it a little bit is, number one, you know, just remember we're all built to survive famines, right? So when we eat a nice meal, your body says, good job. You're saving up for that rainy day, right? And if you get hungry, you're just looking for stuff all the time, right? Because your body's saying, if you do not eat, you're going to starve to death. You're going to die if you do not find something to eat, right? I mean, it's really that simple. And so, you know, if we were having famines every 10 years or terrible times, you know, the people who can pack it on and are looking, you know, they're the survivors. You know, the little size 6 people, you know, they haven't survived. But we don't have those right now. So just remember, you're always getting those messages. If you have a good meal, your body's saying, good job. But if you're not a little uncomfortable, you're probably not losing weight. So diet, you know, eat less, eat healthy food, move more. You know, for me, probably work less, move more. Build muscle. You know, think of muscle, you know. You could probably do worse things than spend your money on a little personal trainer if you don't know what to do. If you know what to do. You know, if you get a little muscle mass, just think it always acts like a little bit of a furnace. It's always kind of on a burn and stuff. You know, as we get older, our muscle mass goes down. So if you can keep muscle mass up, burns up fat, keep your balance better, all sorts of things. So be mindful of that. 3S diet, this is from my wife, who's wonderful. I'd be a very different person without her. No sweets, no snacks, no seconds. I call it no fun, but it's quite good. It's quite good. So living to be 100, 50 words to remember, okay? If you want to live to be, and look reasonable maybe. You got to watch what you ask for sometimes, you know. Not everybody who's 100's looking good. But anyway, you know, don't smoke, and that includes marijuana. If you want to eat marijuana, go ahead, but don't smoke anything. Get vaccinated. If you're from Ashland, you may disagree, but you know, my wife and I were in Peace Corps. We saw a lot of kids die of measles and all sorts of communicable diseases that we've worked so hard as a society to eradicate, and then we're going to reinvent the wheel. You know, a little history is always a good thing to know. Avoid trans fats. Now, what's a trans fat? Trans fat are your fried foods, you know, your donuts, your sauce, you know, your sausage biscuits and gravy, Crisco, French fries. Replace saturated fats with unsaturated fats if you can. So, you know, regular milk, maybe you go to skim milk, maybe if you have regular, you know, or if you have pork or meat, maybe go to chicken and fish, be better. Salmon, particularly. Cook from whole ingredients and minimize restaurant meals. Minimize ultra-processed food. So this is stuff like, I'll show you some examples. Like those Count Choculas and Captain Crunch Berries and cookies and things, everything that's just been beat up and pulverized and comes out in a paste, and then they add all sorts of things. Cultivate relationships. There's actually some great things, and maybe you may not have the luck to have family or friends. There's actually things where in Japan, there's a great National Geographic in January where they have little robot dogs. Everyone needs a little companionship, some way, shape, or form. Nurture sleep. That's something I should improve on, but get it when you can. There's a lot of things, sleep, you burn more calories during sleep than when you're just sitting here. It's a very active process, actually, in terms of dreaming and different things, and your heart rate goes up and down and does all these things. But it's also a kind of a regenerative thing for your brain, processing what's going on. And if you're sleep deprived, it's really tough on your system over the long haul. So, drink alcohol at most moderately. So for guys, like 2 drinks, women 1 drink roughly. If it's 1 or 2 bottles of wine a night, probably too much. Exercise as often as you can enjoy. Drink only the calories you really love, and get a little sunshine on your head. Get outside a little bit. And so, it's not too much rocket science. I mean, frankly, this list will probably get you farther than all the high-tech stuff I showed you. So things that are trans fats, donuts, cookies, crackers, muffins, pies, cakes, all the good stuff. The really good stuff. I grew up with that stuff. I loved it. Saturated fats, this is the beef, pork, lamb, the high-fat dairy foods, whole milk, butter, cheese, trying to minimize it. People ask me, palm oil, coconut, the tropical oils, those have a lot of the saturated fats. Sorry. There's a lot of misinformation. I think the Coconut Oil Association of America says the coconut oil is really good for you, but it's not. Okay. Ultra-processed foods, these are the foods that go through multiple processes: extrusion, molding, milling, contain many added ingredients and are highly manipulated. I used to love like Captain Crunch Berries growing up and stuff. Bad, very bad. So examples: soft drinks, chips, candy, ice cream, sweetened breakfast cereals, chicken nuggets, hot dogs, French fries. This is like good stuff, olive oil, salmon. If you're not sure what to do, there's some great resources out there, really simple to get at. So again, use your brain, go to the right sources. We're wrapping up here. So American Heart Association, great website for all this stuff. Go to the American Heart Association. They're there. They're your advocacy. They are the American public's advocacy group. They've looked over all the best research over the years. There's a really interesting book called Blue Zones. I read the New York National Geographic article. My wife's read the book. I need to read the book. But it's about this guy who just went out and looked at all these areas where people lived to be 100, and what did those people do? And there's a lot of similarities, really. Not, a lot of the stuff, the American Heart Association cookbook, the Mediterranean diet and all that. So and habits are powerful. If you've got kids at home, start with them. If you got grandkids at home, what you learn when you're young, you'll carry through to your life. Might be one of your best gifts for your grandkids. So healthy diets. These are my kids here, just doing stuff. So a lot of fun, all grown up now. And this is the benefit of a long day of running around. It's always like victory. So last thing are the Asante Achievement Awards. I think this is worth knowing. It's always nice to know what's in your community. I think for those of you who work at Asante, it's nice to be part of something I think special. And I'm really proud to be part of the team here. And so this is interesting. I'll just show you some of the things. So IBM Watson Health, the Watson machine that won Jeopardy and all that. They've been doing this for now about 7 or 8 years, and they kind of put in all this stuff, Medicare information and outcomes and safety information. And how many people live or die, and infection rates, and all these things. And IBM, 7 years in a row, Asante has been considered a top 15 health system in the country. And Rogue Regional Medical Center, top 100 hospital, 5 years in a row. Let's see, CMS, which is Medicare, lowest heart attack 30-day readmission rate in the nation, #1 in the nation. Top 49 hospitals with the lowest heart attack mortality rate. That was in 2016. This is our CCU and ICU getting these awards for excellence. You have to have certain things to even be considered. So really good tier. This is the heart attack program, the STEMI program, ST Elevation MI program. And so, Gold Plus as a receiving center. This is really the only, we're the only hospital in Southern Oregon other than Klamath Falls and Roseburg doing heart attack for ST Elevation right now. 5-star rated CMS program. So CMS means Center for Medicare and Medicaid Services, so Medicare. And so in 2017, 2018, 2019, 2020, these hospitals generally got 5-star, some got 4-star. I'll show you that. Leapfrog is a high quality group. We've gotten 2016 to 2019. So that's a very rigorous program. There's CareChecks, which also uses Medicare data for outcomes like in terms of survival and safety and costs. And interestingly, #1 in Oregon in heart attack treatment and safety in 2018. This was really in Oregon, heart attack treatment, medical excellence. And this was really, we were kind of surprised. We were like, is this for real? But in that year, we got #1 in the nation, interventional coronary care. Last year, I think we were like #8 or something. So that was nice. And there's like over 1,400 programs. So that was nice. And then this just came out in November, December. IBM Watson Health listed Rogue Regional Medical Center as a top 50 cardiovascular center in the nation. And there's over 1,400. So that was nice. So CMS awards, this is Medicare. In 2018, only 5 Oregon hospitals were awarded the 5-star rating, and 3 of them were Asante. That includes OHSU, Sacred Heart in Eugene, St. Charles in Bend, Providence. I don't think any of them got the 5-star that year. In 2019, only 3 Oregon hospitals were awarded 5-star ratings: Rogue Regional, 3 Rivers Medical Center, and OHSU. Ashland was a 4-star. And in 2020, all 3 Oregon hospitals were 5-star. I think there were 8 5-star hospitals in Oregon. And that's out of like 41 hospitals. So Asante, I think, is doing a good job. We can be proud of Asante. It's better than most communities like us would expect to get. And then this is the last few slides. I just like to show that. I always like this. This is kind of stuff I like to live by, or things I enjoy. Hippocratic Oath, do no harm. Dr. Francis Peabody, he was at Massachusetts General Hospital. The art of caring for the patient is caring for the patient. Sounds stupid. Sounds obvious, but it's easy to go off into the weeds. The Doctor by Sir Luke Fildus. This was on my doctor's office. When I grew up, my family practitioner, when I grew up, had this picture. It shows the doctor worrying about a child and mom and dad. So I've got that in my office. Sir William Osler, he was at Johns Hopkins, one of the foremost clinicians of his day, went to Oxford after that. His son died in World War I, his only son. It's really quite sad, in the Battle of the Somme. But these are great reads, Equanimitas and A Way of Life. Great reads for doctors. And this is a great book, Better. My wife recommended I read it. It took me a while, but then I finally did, and it was great. Really, probably one of the best books I read in the past 10 years. And Mayo Clinic, the main purpose to be served by the clinic is the care of the sick. And I think the cardiovascular group here really, we quote this a lot. And I think it's easy to get tied up in other stuff, but that's what it's about. So anyway, I hope that's really the end of it. I hope that gives you a lot more information than you had before about how the heart works and what's out there and how to keep yourself healthy and to be critical and what you see out there. There's a lot of misinformation. You know, use your thinking hats, and that's it. Thank you. Great.